Hello and welcome to today's Connect and Learn webinar. It's great to have you all with us. Today's topic is responding to new psychoactive substances in the AOD sector. Before we get started on the topic and handing over to our presenter for the day, I would like to acknowledge the traditional owners of the land from where we are presenting today, the Wurundjeri people of the Kulin Nations, and I'd also like to pay my respects to elders past, present and emerging. This webinar is part of a series and it's been designed to support alcohol and other drug workers and clinicians throughout regional and metropolitan Victoria. It's funded by the Victorian Department of Health and Human Services and hosted by Turning Point. My name is Phoebe Spry-Bailey. I'm one of the Education and Training Officers from the Workforce Development Unit at Turning Point, so I will be facilitating today's webinar. Part of my role as the facilitator is to respond to any questions you may have, so please use the icon at the top of your screen to ask these questions. The other thing I wanted to point out too is Rita, our presenter, has given permission for her slides to be shared with you all, so there's a PDF version of that and she's included lots of links within her PDF version, so please feel welcome to follow up on those. And the last thing I just wanted to mention is the survey feedback. So ideally, we'd love you to stay to the end of the webinar and complete the survey feedback. But if you do have to leave early and you want to provide some feedback, then feel welcome to click on that icon too at the top of your screen. So without any further ado, I'd like to introduce today's presenter, which is Rita Bryan. Rita is a colleague of mine within the Workforce Development Unit. And to me, Rita is our resident knowledge bank when it comes to all things to do with new psychoactive substances. She's also, as I said, she's an education officer at Turning Point. She's been delivering professional development training and community education about alcohol and other drugs. She volunteers with local harm reduction organisation. She's passionate about empowering people to make safer choices about their alcohol and other drug use. Rita recently completed her Masters of Addictive Behaviours at Monash University, researching the capacity of the AOD workforce to respond to new psychoactive substance use in Australia. And today we'll be presenting some of her findings and also lots of other information about new psychoactive substances. So I would like to welcome Rita to the webinar and I'm handing over to you.
Thanks, Phoebe. It's great to be here to talk to everybody today out there in webinar land about this topic. Realistically, the topic came about out of the research project that Phoebe's just mentioned that showed despite prevalence of NPS, new psychoactive substance use being quite low in the community, there really does seem to be growing concern amongst the AOD workforce about how to respond, and hopefully we can address some of those issues today. So firstly, we'll look at some definitions and backgrounds, a little bit about what we know, a little bit more about what we don't know about these new substances, and then we'll get into exploring a bit of a brief overview of the common classes of NPS that have emerged in Australia and ways that we can attempt to reduce the impact that potential harms that some people might face. I do want to point out before we kick off that to get through everything that we want to get through today, there's a lot to jam pack in. So it's a bit of a whirlwind overview of certain substances, but for those interested in learning a little bit more, I have provided links, like Phoebe said, to a range of other good resources for further learning and a little bit more in-depth information about different substances. So what are NPS, or new psychoactive substances? There's no actual universal definition for newly emerging drugs, but globally the term new psychoactive substances has come to reflect a bit of an umbrella terminology for a number of different substances that have been designed or tend to be used to mimic the effects of illicit drugs that we're more familiar with, things like stimulants, hallucinogens, depressants. Often they've been developed either for a therapeutic purpose and or to seek out new sources of pleasure, and in many cases to avoid legislation or international drug controls, or to produce cheaper substances in countries where it's not illegal to produce them that mimic the effects of substances we're familiar with to reduce supply costs. But most commonly, as you'll see on the slide, they're defined as any plant-based or synthetic material that has a psychoactive effect that's not scheduled under the international drug conventions and traditional legislation or traditional legislative controls. And many of them are considered to pose, or some of them are considered to pose, a comparable public health threat to those drugs that we are familiar with. And we're talking about a really vast range of different substances and compounds that have emerged in recent years over the last decade or so. And some of them are known colloquially as herbal highs, even though they might not necessarily be herbal. Legal highs, things like bath salts, synthetic cannabinoid receptor agonists, synths, synthetics, research chemicals, drug analogues, designer drugs are some of the terms we know. And it's kind of important to note there's lots of variation in the range of substances that we talk about under this umbrella terminology, and that can be a bit problematic, grouping together so many different drugs under the one definition, because literature can sometimes be unclear exactly what compounds we're talking about, and we'll get into that a little bit later. So today we'll specifically focus on some of the more common NPS that have emerged as drugs of concern, certainly on Australian markets anyway. So what do we know? We do know that at least 900 new substances have been identified since the United Nations started reporting on NPS, roughly a decade or so ago. We know that at least 100 to 200 of those have been identified in Australia. That being said, I want to point out that very few NPS really do establish themselves on drug markets, and only a few tend to pop up regularly. But despite that rapid growth of new technology being able to develop new NPS in recent years, prevalence of use really does remain low amongst the general population. Although it's kind of important to point out that among some higher risk drug using cohorts, we do see elevated levels of use. So that might be regular psychostimulant users, vulnerable youth, maybe forensic and homeless clients, and sometimes populations of people with complex mental health comorbidities as well. And we do see we have seen, despite the low prevalence, increasing rates of acute and some chronic harms. Certainly we've seen in some of the literature that NPS may be a marker for problematic substance use amongst some groups, and maybe even associated with higher risk behaviours and or dependence in some groups as well. So we also know that there's gaps in knowledge and service provision about new psychoactive substances, specifically in the health and community sector. There's debate about what constitutes best practice service provision, but experts do agree that NPS should be considered at every stage of AOD prevention, treatment and harm reduction. But we know health and community workers report low confidence and limited knowledge about these substances. So that's kind of the point of today's webinar, is to boost that confidence. And just to point out that the primary intervention that we need to consider and use in relation to NPS really is harm reduction, and that the existing drug and alcohol knowledge that you guys already have is highly relevant for preventing harm associated with NPS use, as well as, you know, the traditional drugs that you might be more familiar with dealing with. So just quickly to cover off on some of the issues that arise as a result of having new chemicals emerging rapidly. As I said, few of them become established on drug markets, but their effects are not really well understood. We have a really limited history of human consumption of these drugs, and there's lots of them around. So harms are not particularly well understood or documented or researched. And certainly here in Australia we have limited data monitoring systems and early warning systems. There's no centrally managed data repository about NPS yet that has been established, or public access to information that could help sort of alert us about what's going on with some of these drug markets. And as previously sort of noted, we have seen increasing rates of NPS-related harms, particularly acute harms, spikes in ambulance presentations associated with some NPS, and some emergency department acute presentations as well. Another issue is that the legislation about these drugs can be a little bit ambiguous, or people's perceptions certainly can be. When they were first detected, specific NPS were banned as they popped up and came along, but realistically new ones would regularly appear almost as quickly as other ones were banned. And more recently in states like Victoria, we've seen blanket psychoactive substances bans that make it illegal to produce, sell or promote any substance with any psychoactive effect, regardless of their chemical makeup. There are exclusions like alcohol, tobacco, caffeine, unsurprisingly, or anything else that's regulated by the TGA. But that's not the case in all Australian states and territories, and these laws are fairly new, which leads to confusion about their legality, and sometimes that carries on to false perceptions about their safety because they're not illegal or perceived not to be illegal. And we don't know a lot because of that, and because of the limited monitoring systems. We don't have a lot of information about people's motivations for use. We know some of these substances can be quite cheap and accessible. There's those false perceptions of safety and illegality or legality. We also know that some people might be using them to avoid drug detection, people exposed to drug testing in the workplace, maybe under treatment mandates, or people engaged in criminal justice system or worried about roadside drug testing. But we also know that people seek out new psychoactive experiences all the time and may just be using them for those purposes. Evidence is sort of starting to emerge, mostly from Europe, that people who use NPS may be less likely to present to AOD treatment services. They may not be the typical treatment-seeking cohort that we're used to seeing and talking about, which I want to point out that we kind of need to be mindful about the valuable role that peer support, outreach and harm reduction services can actually play in reaching people who might be using NPS and delivering the right harm reduction messages to them. And last but not least, probably one of the most significant concerns about some of these substances is the threat that they pose when people are using them unintentionally. So there can be a really significant variation between what people think they're taking and what they're actually taking, because they can be used as cheap adulterants or contaminants and or substitutes that are sold as other substances that people think that they're taking. So in terms of who is using them actually intentionally, as I said, data's quite limited to only a few sources, and none of the samples, none of the data sources that we've got are completely representative of all drug using cohorts, and certainly none of them account for unintentional use. But the National Drug Strategy Household Survey commenced monitoring NPS in 2013, and they asked about synthetic cannabis separately and then grouped all other NPS together. And as you can see on the graphs, in 2016, about only 1% of the population had reported using synthetic cannabinoids in the last 12 months, and only 0.3% of the population reported using other NPS. So as I said, rates are quite low. We have seen an increase in lifetime use between 2013 and 2016 of both categories. But rates of recent use have actually significantly declined, and that might be partially due to new legislation making them, removing them from shop fronts in many states and national bans on importing NPS. But I think maybe in the case of synthetic cannabis or cannabinoids, some research suggests it may also be because people have been having unexpected or unpleasant experiences and not going back for more. But we don't really know exactly why that is. And if we look at a couple of cohort studies of regular drug users, like the EDRS, the Ecstasy and Related Drug Reporting System, or the Global Drug Survey, rates of use are a little bit elevated compared to the general population. So in the EDRS, we have a cohort of about 800 to 900 regular psychostimulant users, and NPS use has been as high as 31 to 45% since they started collecting data about this in 2010. The GDS is the largest global online sample of people who identify as drug users, and that shows an average rate of NPS use around the 4 to 5% mark. So it's still significantly lower than traditional substances, and Australia sits just above that global average. Interestingly though, in the GDS, people using novel psychoactives or new psychoactives intentionally NPS and synthetic cannabinoids were actually the third and fourth highest substances requiring acute emergency medical presentation in one of the more recent GDS surveys. And that's after heroin and equal with methamphetamine and higher than alcohol. And synthetic cannabinoids certainly present quite high in acute adverse events as well. That being said, it's important to point out that there is no distinct profile of people who exclusively use NPS, and it's unsurprising that people who use them tend to be polydrug using cohorts, so some of those risks may be associated to the way they're being used. So when we conducted a survey, we were exploring Australian AOD workers' attitudes and experiences and self-reported knowledge and confidence about responding to NPS. I want to point out it is preliminary data and it hasn't been peer-reviewed as yet, but we did get responses from about 189 Australian workers this year. Nearly a third of them worked or volunteered in harm reduction or peer support settings. And while the sample was fairly, or mostly from metropolitan Victoria, its characteristics were fairly representative of other national AOD workforce surveys. And when we asked people about whether they do work with clients who use NPS, 83% of people responded yes. And when we then went on to ask them to estimate the percentage of clients that had disclosed NPS use to them, responses ranged from 1 to 95% of clients. About a third of them estimated NPS use in 10% or less of clients, so not high rates, but another third reported NPS use in 30% or more clients. So that suggests that maybe NPS use is prevalent amongst some Australian AOD service users, including peer support and harm reduction services, and lends support to the idea that they definitely should be considered when working with AOD clients. So just a quick summary of this research that we did. Nearly all of our respondents considered it very or extremely important for workers to be informed about changing drug market and trends, to screen for and assess for NPS use in AOD settings, to understand their effects and potential harms, and to discuss NPS specifically with clients who use them. But not everybody engaged in these practices all the time, and we sort of wanted to tease out why that might be. One of the things was workers reported limited knowledge about NPS, specifically relating to the prevalence of their use, which is unsurprising, data's not great, and how they interact with other substances. Again, easy to understand given that we don't have a long history of researching these types of drugs. And when we invited people to comment about the barriers and challenges that they faced, the majority of these were absolutely directly related to lack of knowledge, accessing reliable and up-to-date information about NPS. Some were concerned about the fact that people who use NPS have limited awareness about the potential of harm, and certainly people were concerned about NPS-specific training for workers. We were a little bit surprised to see that at least 2/3 of the sample of workers had recently accessed information about NPS. And it might show that we had recruited a slightly biased sample of people who were specifically interested in this topic or engaged with lots of clients who use them. But when we asked whether NPS resources and information available to AOD workers was adequate, 6 in 10 workers responded no. What was really interesting though, recent access to NPS information in the last 6 months was directly associated with workers' confidence delivering brief interventions and harm reduction advice to clients. So only 1 in 5 workers were very confident discussing NPS with clients and or providing interventions, but those who had recently accessed NPS information either online or via newsletters or done extensive research, they were the ones who were significantly more confident than people who had not accessed information about NPS. So we know we can boost confidence by providing information to workers and to reaffirm for you guys that a lot of the information that you need is information that you already have, the existing knowledge that you have about harm reduction and drug interactions. And people were mostly interested in general information about NPS, substance risk profiles, and harm reduction strategies and messaging. So that's what we're going to crack on with now and chat to you about in a little bit more detail. So I alluded to the fact earlier that using overarching terminology like NPS, it can be helpful to group together an overwhelming number of different individual chemical substances and compounds. but it really can be problematic to use umbrella terminology to lump a whole bunch of different drugs together. There's so many diverse substances out there, and it's not particularly informative just to say NPS. And it really gives us no idea about the specifics of the compound itself or its effect risk profile that somebody might be exposed to. And I certainly saw this in my research study, where it was clear for some of the commentary that different groups of workers were definitely seemed to be thinking of different substances when they were responding to some questions. Some sort of seemed to be focusing on synthetic opioids, others might have been talking about unintentional drug use in the festival or party drug scene, and others seem to be leaning towards concerns about synthetic cannabinoids, and I think that's directly related to their experiences with clients. So we know, as AOD workers, a helpful way to classify substances is based on their effects on the central nervous system. And on the slide are some good resources that group individual types of NPS into these types of CNS classifications, sort of that reflect more the drug's effect profile. The one is from the British Medical Journal, and there's a link there in the slides for you. And another is the ADF Drugs Wheel, which is a new interactive tool, and it's a particularly good place to start as it goes a little bit beyond the basic depressants, stimulants, hallucinogens, and teases out some of those effects that people tend to report experiencing a little further. But another way to consider these substances is based on their chemical classification that is loosely tied in with these general effect profiles. And that's kind of how we're going to look at them today to demystify some of the information about common classes that have sort of popped up as problematic in Australia. I do want to give a little caveat that some NPS are structurally diverse. We're not covering a comprehensive list here today, and some are not confined to one particular category at all. There's considerable variation in how different people tolerate drugs and experiences these substances. So like any drugs, the effects vary based on the drug, the setting, and that's something really important to bear in mind. And not everybody is going to experience harm with any kind of psychoactive substance use. So we're going to start off with synthetic cannabinoid receptor agonists. I'm going to call it synthetic cannabis or SCRAs because it's much easier to say and I get tongue-tied quite easily. But synthetic cannabis is a new psychoactive substance originally designed to mimic or produce similar effects to cannabis, and it's been sold online, we think, about since 2004. Initially, these were generally synthetic chemicals that were functionally similar to THC, the active ingredient or the psychoactive ingredient in normal cannabis. However, some of the newer substances that have come along claiming to be synthetic cannabis really may not be structurally similar to THC at all. Also, often these products don't necessarily include analogues for other cannabinoid receptor agonists that can sort of temper or ameliorate some of the psychedelic effects that people experience with a THC or a THC-like experience. So in the same way that something like CBD might ameliorate some of the side effects of THC in natural cannabis can often be missing in some of these products. But initially, they were developed to be analogues functionally similar to THC, but now we're seeing a wide group of different type of substances that are either soaked or sprayed onto a plant or herb material, usually plant matter. Usually it's an inert herb. And when combusted and smoked, the reaction can sometimes be volatile and quite irregular in action and very unlike the traditional cannabis experience for some people. Less frequently they're available in a liquid or oil format, but we're probably seeing them more in terms of this plant matter or affected plant matter. The effects can be really inconsistent, even across batches of the same brand, but also within batches of the same product. So regulating dose with these drug guys can sometimes be extremely problematic. And the strength of synthetic cannabis and the chemicals used can vary significantly from batch to batch. And that makes it really hard to predict what the effects will be. And we have seen some increasing harms. As I said, prevalence of use is quite low, but we've definitely seen in Victoria a spike in synthetic cannabis-related ambulance attendances since 2015, for example. And we know anecdotally there may be increasing prevalence of use among certain cohorts that are maybe more vulnerable. Data certainly from the UK is starting to show an increase in use and harms in groups, even a shift from people who inject drugs moving over to synthetic cannabinoids, possibly because of price and availability, but also in scenarios where people are subjected to drug testing, like I already said. So who's using them, or why would people use them? Really, it seems the primary reason is being unable to access natural cannabis for a range of reasons. When asked, people tend to prefer natural cannabis first and foremost. And in terms of their effects, at times the effects can really be quite similar to cannabis as we know it, although that's becoming less and less likely now as many original strain chemical compounds have been banned and a lot of new different ones are popping up. But often we see an effect profile that is actually not typical to cannabis at all. And if you have a look at the side at some of the short-term harms we've listed, they really are much more typical of what you would see in stimulant or methamphetamine type harms: cardiovascular issues, agitation, severe anxiety, paranoia, racing thoughts, even seizure or strokes at the worst end of the spectrum. So we're definitely seeing this unique intoxication and even withdrawal profile with these substances. So in terms of withdrawal, I've popped up a little table here that comes from a different webinar about NPS by Dr. Stephen Bright that was put on by the Matilda Centre. Some of the underlying symptoms in intoxication and withdrawal sort of highlight those unusual symptoms that we sometimes are seeing. Withdrawal services tend to be reporting quite complex management with synthetic cannabinoids, and as I said, symptoms you wouldn't normally see. It's being also reported from some users that withdrawing from synthetic cannabis can be quite different to that from normal cannabis, and I think this is a key thing to point out. Withdrawal can be far more severe. It can start within a few hours of ceasing smoking. It can peak on day 2, which is quite different to the profile we would normally see with cannabis. And there's been reports of severe stomach cramping, people experiencing insomnia, paranoia, panic attacks, agitation, anxiety, mood swings, rapid heart rate. Look, for most people, these will resolve quite quickly, but in some cases, a short course of benzodiazepines or fluids or antiemetics to reduce the nausea might be helpful. But we would really recommend, if someone you're working with wishes to cease using synthetic cannabis, we would really advise exploring a residential withdrawal if that's an option. And if it's not possible, we'd recommend some form of medical management or observation of the person just to ensure that they're not at risk of some of those nasty side effects. In terms of long-term harms and effects, we have limited info, but again, anecdotally, we're starting to see reports of people reporting dependence with synthetic cannabinoids. And unlike normal cannabis that we're used to, where overdose is almost non-existent, we have been reports of overdose and adverse reactions for use of SCRAs. I do want to point out severe adverse events and deaths are relatively rare, although a recent report from Shane Dark at University of New South Wales has investigated circumstances of at least 55 deaths where SCRAs were implicated. But that said, most acute presentations in an emergency department don't exceed 8 hours, and symptoms are often ameliorated quite quickly with symptomatic care. And that's the case with lots of NPS. Often it's just a matter of addressing the symptoms like you would in an everyday clinical response. In terms of harm reduction messaging though, we might encourage people to mull up their entire batch entirely from the outset to ensure they mix it as evenly as possible. We would never really recommend mixing with a substance like tobacco because of the obvious harms there, but we would recommend mixing these drugs and not smoking them safe. We would certainly say don't use alone because of the risk of some side effects and to be mindful of those harmful side effects, specifically in terms of limiting dose and trying a very small dose very quickly. Less than the size of a match head to start with, or a fingernail could help gauge the strength and possible effects to some extent. Dosing should be increased slowly, and we'd really recommend against using bongs or pipes because, again, people are reporting higher risk of overdose or bad reactions smoking in pipes. And it absolutely shouldn't be used if someone has a pre-existing cardiac or mental health condition. So another type of NPS that we hear about, depending on who you ask, phenethylamines or phenethylamines. They're a class of drug with documented psychoactive and stimulant effects. Two types of phenethylamines that are not NPS, MDMA and methamphetamine. They're examples that are controlled under the conventions. These drugs tend to have stimulant properties, but really often have a hallucinogenic or that entactinogenic, empathinogenic effect, something like MDMA. Some examples of new and emerging phenethylamines in Australia include, and they're in bold on the slide, the 2C series, the NBOME series, and drugs known as PMA or PMMA. So although 2CB itself is no longer considered an NPS, it's been recently scheduled, or not that recently, in 2001, other drugs in this class are derivatives and are considered NPS. And they tend to have quite a psychedelic effect. PMA and PMMA are also not particularly new substances and are very close relatives of the MDMA family, but they're manufactured in a very similar way to MDMA is, just using one different precursor in the process. I'm pointing out PMMA, it's not particularly prominent in Australian markets, but we know when it's around because there's almost always a death associated with a standard dose of PMA or PMMA sort of each time it appears on the market. It can have a much longer onset than MDMA, so people, and quite a strong effect, and be quite toxic at relatively low doses. So people can not feel their drugs coming on and be likely to redose and expose themselves to higher levels of toxicity. In some cases, we hear reports of taking up to 2 hours for the full peak effect to come on. And we know that there's been at least 100 deaths in the UK and certainly at least a handful of deaths here in Australia related to PMMA. So it is a concern when it is around. The NBOME series, on the other hand, are usually known as 25I, 25C or 25B NBOME. We tend to group them together. They're derivatives of the 2C, 2CB series, albeit more potent. And these tend to have very, very strong hallucinogenic effects. PMMA and NBOME are more frequently being missold as toxic surrogates for other drugs, often MDMA and ecstasy. And tend to be active, as I said, at much lower doses than MDMA normally would. So there is a high risk of reaching toxicity and overdose if people are taking them unwittingly, if they're expecting a different type of drug effect. The way they tend to be distributed, NBOME was certainly initially distributed and sometimes still is on blotters and missold as LSD. But has a much more potent and very toxic effect that might surpass the psychedelic experience that somebody is experiencing. That may be less problematic if somebody is experiencing a psychedelic effect, but this is the first time that we've seen toxic adulterants in the LSD market as such. And what we're hearing about now is certainly NBOME and sometimes PMMA being sold in powders or crystal form, or in capsules or in tablets, and as I said, as adulterants or substitutes for MDMA and ecstasy. Sometimes there's even small amounts of MDMA in those samples that are being sold, which the only reason we can think of why that would be to full reagent drug testing to test positive for MDMA. NBOME specifically has quite a low bioavailability and it's very dose dependent. So you need a larger dose to get a stronger effect. And the active dose is actually quite active at the microgram level, so very, very small amounts. Swallowing or ingesting it is far less effective, so people tend to have higher doses if it's been sold to be ingested orally. And snorting NBOME is really problematic. Because it increases its bioavailability and increases the likelihood for toxicity. And you're also bypassing that gut response where somebody might, somebody might throw up to sort of, evade being poisoned. You're sort of bypassing that when snorting. And we have seen cases where people have died snorting NBOME at higher doses. We don't know a lot about withdrawal and dependence for obvious reasons. Prevalence is no. But again, if somebody is presenting with acute intoxication, we would recommend obviously managing the symptoms. In summary, the harms, they're highly toxic. The body can reject the substance quite quickly. Much lower thresholds for a psychoactive effect than LSD or MDMA. much longer onset with some of these drugs, so people can often redose if they're expecting an effect to come on quicker. We certainly would recommend against snorting, and there is an increased risk of seizure or serotonin syndrome with taking phenethylamines, particularly if they're being mixed with other serotonin-acting medicines or drugs. Just as a quick recap for those who aren't familiar with serotonin syndrome, it's a group of symptoms that occurs when somebody has used, multiple serotonergic medications or drugs together or at high doses. Really what happens is you get excessive serotonin in the brain and the central nervous system. The body loses capacity to regulate temperature. It can occur on a spectrum from quite mild to quite severe, but you can end up with dangerously high body temperature, agitation, confusion, at the worst end, tremor, seizures, and severe organ damage from that overheating. And it's commonly, as I said, caused by mixing medications, specifically drugs like monoamine oxidase inhibitor antidepressants, which aren't as frequently prescribed as serotonin SSRIs, selective serotonin reuptake inhibitors. Drugs like tramadol also affect serotonergic activity, so taking them in conjunction with drugs like MDMA or NBOMe can be problematic. And another drug called DXM, which is actually available in some over-the-counter cough syrups, can be highly toxic with drugs like MDMA and NBOMe. So it's just worth making sure that people, maybe not saying to people don't mix drugs, but presenting some of those high-risk combinations so that people can be aware of them. Before we move on, I just want to point out one example of phenethylamine NPS being associated with adverse events here in Australia fairly recently, summer of 2017, that was linked to induced toxicity and probably partial serotonin syndrome or serotonin syndrome-like problems. There were a spate of poisonings that occurred at a Melbourne nightclub district that resulted in 20 hospitalisations and 3 deaths. And when the substance in question that was sold as a capsule, as you can see on the screen, were forensically tested, there was quite a high amount of NBOMe and another phenethylamine 4-FA and a small amount of MDMA present. And from anecdotal reports, we know those who ingested it may have had an uncomfortable experience, not all of them, but some of them did. But it seems that for those who snorted the substance, the outcomes were far worse and they were more likely to end up hospitalised or even deceased. So in terms of harm reduction, mindful of dangerous drug combinations, definitely avoid snorting drugs if you're not absolutely 100% sure of what's in them. In terms of NBOMe, it has a very unique bitter flavour, so there's a good catch cry. If it's bitter, it's a spitter. We would also recommend that if people are using powders or pills, to crush them up evenly and mix them up evenly, to have a dab, to take it orally, and to wait 90 minutes, 120 minutes even, and be mindful of not redosing too quickly. So start low, go slow, really is a strong message. And we'll talk about colorimetric reagent testing in a minute, but it's important to point out that there are limitations in testing drugs at home in uncontrolled environments. However, they can provide a really good estimation of what is or what isn't in a substance when somebody doesn't have access to other strategies. Another type of NPS that I wanted to point out and rush through briefly are synthetic cathinones. So these tend to be sold as powder or crystal-like and often were once known as bath salts or packaged as bath salts. They're closely related to the phenethylamine family and typically they tend to be amphetamine-like stimulants or stimulant-like analogues. They first appeared in drug markets in about 2000. Methylone and mephedrone are probably some of the more well heard of ones and the first ones that were reported. Mephedrone was quite popular in the UK. It never really gained much prominence here in Australia, although a couple of cathinones that we are hearing about, at least in the media, are alpha PVP, otherwise known as flaca, or MDVP monkey dust. Look, these drugs are not particularly prevalent here in Australian drug markets, or certainly intentional use of them isn't particularly prevalent as far as we can tell, probably because we have a really readily available amphetamine market, so there's not a big demand for their use. But on the other hand, there is some evidence from wastewater analysis that they are around, and some reports that people might be using them as synthetic cocaine or synthetic stimulants to avoid drug testing. So they have very similar effects to stimulants that you're familiar with, euphoric effects, They can be quite short-acting, so there can be quite a really strong desire to redose. And the risks are the same as those for stimulants that we know. So again, in terms of acute toxicity, dependence potential, withdrawal, we would manage as per stimulants and deal with someone's symptoms. One relatively new cathinone that has emerged recently is N-ethylpentalone. It is increasingly being detected in samples thought to be MDMA or ecstasy here in Australia at the Grooving the Moo drug testing trials in Canberra, in New Zealand and overseas in the UK. And it's a very, very powerful stimulant, often with short-lasting some effects like MDMA, but they tend to wear off quite quickly. So again, people tend to redose, and they can be having very strong stimulant effects for 48 to 72 hours at higher doses. So we really want to get a message out there that people need to know what's in their drugs, to start low, to go slow, to seek help if they're not feeling well. In the event if they have accidentally taken an ethylpentalone, rest is the most important thing. Try to help somebody ride out the uncomfortable experience, stay calm, don't be alone, and understand it's the drug, it's not you. I do want to touch on synthetic opioids, but really as AOD workers we're usually pretty familiar with the harms and the risks associated with opioids, and they're very much the same with synthetic opioids, except for the fact that they are more potent and often can be faster acting. So two common ones that we're hearing about are fentanyl and carfentanil. They're much more rapidly absorbed than morphine or heroin, and they can have quite high potency. So they do have quite a high potential for overdose risk, particularly fatal overdose. And that's because of that potency and absorption, maybe fluctuations in concentrations between batches and indistinguishable variations between, you know, an appropriate and what could be a dangerous or lethal dose. And because of their onset of action, there's less time to intervene. So we know that pharmacologically, naloxone works for fentanyl, should work for fentanyl overdose, but we might need higher doses of naloxone, or more regular dosing may be needed. So events where naloxone hasn't worked in fentanyl, deliberate fentanyl use, it could be because of delayed administration or high doses consumed. So instead of having, you know, minutes to an hour to respond to an overdose, we might only have several minutes to respond in time. And that's probably the biggest concern. That said, fentanyl use in Australia is relatively small compared to heroin. The majority of fentanyl use is not from illicitly imported fentanyl. It tends to be from diverted analgesic medical patches, which is prescribed for cancer pain or after surgery. And use is quite low, but we are seeing increased rates of fentanyl use, and overdose can be, you know, twice as likely for fentanyl users than heroin users. So it is something that we need to watch, especially because of the fentanyl crisis in America. But we certainly aren't seeing that here yet, but it is something to be alert for. And realistically, one of the best responses we can have is ensure that anyone who's exposed to opioids or using opioids has access to naloxone. So that's the whirlwind the four categories I wanted to go through with you guys. In terms of responding to NPS more generally, or EPS, emerging substances, really we want to consider implications of unintentional use as one of the major concerns. But if we are responding to somebody with acute intoxication or experiencing withdrawal, realistically, you just need to address their symptoms. I think there's a real opportunity for us to broaden the scope of AOD services to include NPS and to discuss NPS with clients, and maybe to better engage people who are more likely to come across them and seek them out. And to build workforce capacity, so knowledge, skill, confidence, having better access to information other than webinars, you know, having a good repository of information available. And I think one way to do that is to be better at bringing together clinical expertise, along with people with lived experience to be able to get the right message about what's really going on out there with people using them. Certainly there's opportunities about improving data monitoring and having early warning systems available. But realistically at the moment what we need to do is utilise harm reduction strategies and messaging, and that includes universal harm reduction messaging that you guys are already probably very across. I want to reiterate that traditional substance knowledge is absolutely relevant in a lot of cases with NPS. Obviously, we need to be mindful of some of the unique withdrawal or intoxication risks with substances like synthetic cannabinoids. That's not like normal cannabinoids, but otherwise, generally, we want to give good harm reduction messaging. So that is things like carry naloxone, drug setting, all the universal harm reduction messages that we would normally give. Some of the specific ones to NPS and just drug use in general I've touched on already. We've got a list of them there. And where possible, if people can have access to testing kits or testing services to know what's in these unregulated substances. So we don't have time to go into much about reaging and colorimetric at-home testing today, but I would point you towards a great article that was in The Conversation earlier this year by Stephen Bright. It goes through the benefits and limitations of using at-home reagent test kits. Essentially, though, in summary, it does not necessarily suggest that a substance is safe. It cannot tell us about the amount. It's a very binary, subjective test sometimes, and they can be quite tricky to use. But they can identify potentially dangerous adulterants in substances if people are using the right test to test for these adulterants. Some of them won't turn up in these tests at all, though. So that's a really great resource if you want to do a little bit more reading about that. Also, I just want to give a shout out to Harm Reduction Victoria, who also have some really good resources about at-home testing. I've provided you with a list of great harm reduction resources that I think are really useful, both related to NPS but general harm reduction, certainly for recreational drug users. The Global Drug Survey has a really great focus on harm reduction based on people's responses to that survey. The Loop UK. TripSit is a really fantastic resource for people who are a bit concerned about not understanding much about drug interactions, and I'd recommend exploring that further. And Erowid is a great resource as well. Also, online forums like Drugs Data, Pills Reports and Blue Light can be great. I do want to point out that peer-based user experience websites are not necessarily evidence-based in the way that we're used to evidence-based. So caution does need to be executed, making assumptions about the content or effects of a substance without testing it and getting information online. But there are some really great peer-based resources out there that people can access. So just before I wrap up, I just want to point you through to a list of really great NPS resources. One is an online e-learning, a set of e-learning modules about different classes of NPS. It is very UK-based, but it is a really good if you're looking to get into more about the pharmacology of drugs. Turning Point's new alcohol and drug withdrawal guidelines do touch on NPS. From the evidence that we do have, I've already pointed you to the ADF Interactive Drugs Wheel, NDARC and the BMJ also have some good fact sheets that you guys can download and even talk about with your clients. And there's another couple of webinars out there that have sort of popped up in the last sort of 6 to 3 months that I think are useful, and they go into things from a slightly different slant than we have today. So that's pretty much it from me. Hopefully we've got time to go through a few questions if any have come up. I'm certainly happy to respond to them online and offline.
Thank you so much, Rita.
Pleasure.
Fantastic. Wow, so much information, so many links to resources, a really good, I think, starting point for people who want to build their confidence when it comes to working with people who use new psychoactive substances. And I think you can see why I refer to her as our, local, knowledge bank, because she's, she knows so much about NPSs.
I do have to give a shout out to some amazing people in my network, you know who you are, who have been the starting point for a lot of that information as well, just in case you're watching.
So we've got a few questions here, but feel welcome if you wanted to, start typing in questions using the icon on the top of your screen. So I'll just start off, Rita, with this question. So it was mentioned that in your research, the respondents thought it was really important that they screen and assess for NPSs. So what tips would you give people for, within screening assessment about how would they ask someone about their new psychoactive substance use?
Yes, that's something that was sort of came up as a recommendation out of the research project that I didn't get a chance to explore deeper today. I think there's a real case for being a little bit more proactive about screening for NPS. Usually we ask about the traditional drugs that we know about. We know that people don't tend to present with NPS as their primary drug of concern. But if they're using NPS for a range of reasons whilst going through withdrawal or other treatment, we know that that can impact withdrawal and treatment. So I think it's about familiarising yourself probably with some of the drugs that we've talked, or classes of drugs that we've talked about today, rather than saying, oh, do you use anything else? Oh, no, no, and moving on and sort of whipping over it. Just going a little bit deeper, scratching the surface, saying to people, oh, have you come across synthetic cannabinoids or ever tried any N-bomb? If they're into hallucinogens, they might be using something like N-bomb deliberately. I mean, none of this accounts for unintentional use, and that's a concern, but that's sort of a different story than the one that you guys are dealing with. But just drilling down a little bit deeper and just not being afraid to ask, because even if you don't know what that means, it's a really good opportunity to start a conversation and ask somebody what that's like and what that's all about and why they're using it, because you're going to have a better relationship. So reflective listening, like, yeah.
Thank you. Thanks. And there is another question here. So where can I learn more about NPS and how they interact with other drugs?
So I touched really briefly on, certainly I've found the UK resource put together by the Neptune team, which is a link on one of the previous slides. Clinical management of club drugs and NPS. I think that's a really good resource if online learning is your a good mode of learning for you. Also, I would recommend the TripSit drug interaction chart. It's not comprehensive. Information in it obviously needs to be delivered with normal harm reduction cautions and warnings, but it can be a really useful resource about drugs that have lower risk or lower risk of interaction, and some of the ones that have really high risk. You won't be surprised that alcohol ranks really quite high when it interacts with other drugs. So it's a really good sort of matrix that you can line the drugs up and get a bit of background knowledge on their interactions. But that being said, because these are new chemicals and we don't know a lot about them and there's not a lot of research out there, we really just don't have a lot of evidence-based information other than some of the things that we've covered off on today.
Great, thank you. Okay, well that's about it for questions. So big thank you to Rita for coming along today and sharing her knowledge and taking the time out of her day to do that and preparing, because I know it's a big thing, presenting a webinar. Thank you to everyone who's attended today and also for watching it. If you're watching it on demand, all our webinars are available to watch on demand via the Turning Point website. Before you leave, if you could provide feedback about the exit survey, that would be really appreciated. And also what we love is if you've got any ideas for future webinars, or even if you'd like to share some of your knowledge and, would like to present a webinar, please feel welcome to get in contact with us. Our next webinar is on the 21st of November at 1 p.m. It's Online Communities for AOD Recovery, a new and exciting story. Registration will be via the Turning Point website, and we will be advertising it via VADA e-News. So thank you all so much for listening in today. Thank you very much to Rita, and we'll see you next time. Okay, thank you.